Hello, and everyone, and thank you very much for attending this ESO session. I welcome also the discussant, Dr. Curigliano, and we will dedicate this session to highlighting to you the most important in March at the St. Gallen Consensus Conference. So, hold on a little bit while I get the hold of the slides. And these are my disclosures. So, this year, we may say that the most important theme throughout the sessions that discuss new available data in St. Gallen, and then throughout the discussions that took place on Saturday at the consensus session, the most recurrent theme was how can we also discuss when to escalate therapy, but most of the time we discuss on how could we de-escalate therapy, both regarding surgery and systemic therapy, and I will show you that probably a little bit less regarding radiation therapy. But if you keep in mind that this is the message from St. Gallen, that less is very often more when we discuss early breast cancer. So, for those of you who may not be very familiar with St. Gallen, what this conference does is looking mainly at the controversy areas. So obviously, we are lucky enough to have many areas of early breast cancer management that have high level of evidence to sustain our decisions. But there are some areas where the level of evidence is not so high, and where we need guidance and guidelines, and where expert opinion can be used to decide and to help dissect the available literature. So at the Saturday morning session, panelists were asked a series of questions, and they were asked to reply and also to abstain if they felt that they had a conflict of interest or if they didn't have insufficient data or lack of expertise. You will see that this is a very special group of people because very rarely people abstain in the St. Gallen panel. And then we can laugh about it later. So don't forget that throughout the session, it is very important that you submit your questions and comments, and I'll be happy to answer all of them together with Dr. Curigliano at the end of my talk. So let us start with surgery. And we went on to discuss again the appropriate margins. So starting with DCIS, and in case we are breast radiation treatment is planned, the panel felt that the minimum margin is still 2 millimeters. As you can see, perhaps with a lower percentage than in other years, but still 2 millimeters required for the CIS, although about 35% of the panelists thought that maybe the same as for invasive cancer, so no ink on margins could be sufficient. When we were asked if the margin should be dependent on tumor biology, there you have a clear consensus that it should not depend on tumor biology. Then we discuss the extent of surgery in the situation of multicentric and multifocal disease. And while if you have a multifocal disease, so mainly you have more than one foci contained in one quadrant of the breast, and if you are moving for breast conservation, or if you are planning to perform adequate radiation afterwards, you can think of breast conservation, and this is a very consensual reply. 97% of the panel agreed. When we speak about multicentric disease, so you have tumor foci in more than one quadrant, and you're still planning radiation therapy, for the majority of panel, although a less high percentage, 61%, still feel that breast conservation is necessary. So again, saying that whenever possible, prefer breast conservation to mastectomy, obviously followed by radiation therapy. Now, what about the surgical management after neoadjuvant therapy? And this is probably one of the areas where we still have a lot of unanswered questions, but we are starting, probably with more and more experience of using neoadjuvant therapy, we are starting to understand what is the best way to perform surgery after neoadjuvant therapy. So let's assume that we have performed neoadjuvant therapy. It doesn't matter if we're going to do any additional adjuvant systemic therapy, and that adjuvant radiation is planned. So the first question is it necessary to resect the entire area of the original tumor? And this is a clear consensus that we do not need to do that. Obviously, that would be against the main goal of neoadjuvant therapy, which is to reduce the area that needs to be resected. Then when we discuss the minimum acceptable surgical margins, here you see that if there is no multifocal residual disease, everyone is in agreement that what we need is no income margin. But if there is multifocal residual disease, we cannot say that there is a clear consensus. 55% think that no ink in the margin is sufficient, but about 30% still feel uncomfortable with less than 2 millimeters. Now, moving on to axillary dissection, and also one of the main messages of all this discussion that I will have with you is that the message from the panel is avoid axillary dissection as much as possible, as long as it is safe. And so reserve axillary dissection really for the less number of cases as possible. So let's start with macro metastases in the sentinel nodes. So if someone had a mastectomy and removed 1 to 2 sentinel nodes that have macrometastases and no radiation is planned, then everyone thinks that axillary dissection is still necessary. But if radiation is planned, then the majority of panel believes that you can avoid axillary dissection. And just to clarify, this means that you have removed enough number of sentinel nodes to be comfortable with 1 or 2 having a macrometastasis. Now, if breast conservation is the surgery that is planned and radiation is going to be performed, most of the panel is very comfortable that you do not need to go for axillary dissection if you have 1 or 2 macrometastases and you're using radiation with either standard tangents or high tangents. And this is irrespective of tumor biology, be it ER negative, grade 3, or other features. What about after neoadjuvant therapy? Is if a patient was assessed clinically and by imaging as node negative, can we perform a sentinel lymph node after neoadjuvant therapy? And the vast majority said yes. Regarding the best timing, 60% said before neoadjuvant therapy, and then 20% after, and 17% it would not matter. I think that regarding this discussion, other issues are probably to be considered, because if you perform before neoadjuvant therapy, you are demanding the patient to have 2 surgical approaches. And in some situations, that may not be the most appropriate thing to do. So, for example, at our center, but we can discuss in the end, our center, we always perform after neoadjuvant systemic therapy, but something perhaps to take note and discuss in the end. What if someone was clinically or by imaging node positive and it down stages during the neoadjuvant therapy? So when should the surgery of axillary move to axillary dissection? So if there is only 1 to 2 sentinel lymph nodes detected, there is we cannot say there is a consensus in this answer, because as you can see, 54-43 clearly identifying an area where we need more data, because not even the panel of experts can come to a clear recommendation. Now, if more than 2 nodes were detected, then the answer is still a little bit vague, but it seems that it could be more acceptable. In the next question, I would say that it is also something to discuss in the end, because we are discussing here something that it's the marking of the nodes, and the marking of the nodes is something that, in my view, is still to be considered experimental and to be done inside a clinical trial. It's a very promising strategy to mark the nodes the same way as we mark the lesion in the breast, to mark the nodes before starting neoadjuvant. And if they downstage after neoadjuvant, perhaps they do not need to be taken, or only those need to be taken. If they are negative, you shouldn't take any other nodes. I think the panel 50% voted yes, because many of the experts are involved in clinical trials of this technique, which I find very, very interesting. I still have my doubts if we can recommend to be used in clinical practice everywhere. Now, the question then was, can axillary dissection be avoided if micro metastases were? Again, as you can see, there is not a clear consensus, 49 versus 46. So also an area where we don't have a clear notion of what to do. While the last question, if axillary dissection could be avoided if there are macro metastases in just one sentinel node, I think there everyone is in agreement that this situation demands axillary dissection, at least for the moment. So let's move to radiation. And my comment to radiation is that probably of all 3 main therapies for breast cancer, this is still the area where we are down. We are still not ready to de-escalate as much as we are de-escalating in surgery and systemic therapy. So let's go through the questions that were asked, starting with hypofractionation. So the question was asked, first of all, can we consider it as standard of care for all patients? And almost 60% of the panel considered yes, but there are still 25% who do not consider a standard for all patients. And then when asked if this would be a standard for patients, for all postmenopausal patients, and so about 50 years old, and it says here, and most of the panel replied that yes, they would consider. Obviously, this should be discussed on a case by case, because there may be other reasons, technical reasons, comorbidity reasons, or others that would lead not to use hypofractionation, but in the vast majority of cases, particularly in postmenopausal women, this can be considered. Partial breast irradiation. The question was, can we consider it as the only radiation that we perform after breast conservation for those that are considered astro-estro suitable patients? And here, 65% of the panel considers it is enough to do just partial breast irradiation. While for the next category of patients, that is called cautionary in the astro guidelines and intermediate in the estro guidelines, there we really do not have a majority of yes of responders, but 48% do not feel that we can consider partial breast irradiation alone for these patients. As you know, we're performing boost for the vast majority of patients, and the question here is, can we start omitting the boost in some selected group of patients? And The selected group of patients that were asked is above 60 with low-grade tumors or favorable biological profile, and without having a very high percentage, at least 55% of the panel members would be okay to omit the boost in these circumstances. Now, an area where is probably also in need of more data, and we're still waiting for the results of important trials, is the regional nodes irradiation. So let's start with a situation of breast-conserving surgery. When should radiation therapy involve or include the regional nodes? If you have 1 to 3 positive nodes, should you consider it in all patients? Here, only 35% of the panel members would consider to add radiation to all 1 to 3 positive nodes patients, while 53% would consider performing this radiation if there are adverse biological features. Where there is a 100% consensus is if there are 4 or more nodes, then radiation to the regional nodes is necessary and mandatory. What about if mastectomy is performed? When is post-mastectomy radiation, chest wall and regional nodes recommended or considered as standard? And there were several questions that were asked, and you can see that for big tumors or 1 to 3 positive nodes, although the percentage of yes is above 50%, it is not a huge, a very vast majority of the panel members. If you go to 1 to 3 positive nodes with adverse pathology, yes, most panel members would recommend this radiation. And something that was a bit puzzling to me, but although there are a few data showing that young women do have a higher rate of local regional relapse, we have been discussing and lobbying for a long time that young women should not be treated differently just based on age, but taking everything else in consideration. Nevertheless, here, most of the panel feel that at a young age, with 1 to 3 positive nodes, everyone should receive post-mastectomy, or most women should receive post-mastectomy radiation. And then the final question was if there was a positive sentinel lymph node, but no axillary dissection was planned. And also here, about 57% agree that radiation is necessary. By the way, I wanted to remind all of you that a new manuscript from the Oxford Overview regarding radiation therapy is out, and it will be very important for all of you to read that paper. Now, regarding radiation after neoadjuvant systemic therapy or chemotherapy, does it take into account the stage before or the stage after the therapy? And the question, and I believe this is indeed very appropriate, most of the panel feel that it has to take into account both the initial stage and also the response to neoadjuvant therapy and the stage after that treatment. So remember that you can and should send all your questions and comments at any time, and Dr. Curigliano will be collecting them and we will discuss at the end of my talk. Moving on to pathology. So let's start to discuss the use of immunohistochemistry surrogates to distinguish between luminal A-like and luminal B-like disease. As you know, one of the most difficult distinctions, and one that is very important because it has important therapeutic implications. So the first question was, do we consider that by immunohistochemistry surrogates, this distinction between luminal A-like and B-like are important for the biology of breast cancer, and that there is a consensus of 100%. Do we also consider that it can be used to take therapeutic decisions? Also, the vast majority of panel members believe that yes. And when approximate to the multi-gene testing, also the majority of panel members agreed that it can be a good surrogate. And this is confirmed by the next question that says, okay, if we can use ER, PR, and a high category of Ki67, can we use these three markers to distinguish between luminal A and B-like? And also the majority of the panel believes that we can. Obviously, most of us believe that this subtype can be done more accurately when we use multi-gene testing, since they were developed using multi-gene testing. But the surrogates are also very useful in clinical practice. What about tumor infiltrating lymphocytes? And maybe this is something that it's very dear to Dr. Curigliano, but I think, yeah, for the moment, the majority of the panel members is still not considering that it should be routinely reported. My take on this is that we probably do not need to be reported yet, because we don't know what to do with this information. And so more studies are necessary to guide us on what do we do when we receive this information. And so now moving on to multi-gene signatures and the use of chemotherapy, and starting with one question that basically what we want to ask is, do we need to ask a gene signature, multi-gene signature in all luminal breast cancer tumors? And the answer is obviously no. There are situations where we can take the decision regarding chemotherapy without the help of a multi-gene signature. And this case described here is one example. So do we need a multi-gene testing for a node negative, PT1A or PT1B, ER positive, PR positive, HER2 negative, low grade, low Ki67, so clearly a luminal A-like small tumor with lymph node negative? And here I believe that none of us has the need of a gene signature to take the decision. Mind you that I believe there are many more cases where a multi-gene signature is not necessary. And although I have not included here a graphic that I usually present telling you how can we reduce the group of patients where multi-gene signatures could be very appropriate to ask, maybe we can reserve that also for the discussion. And I have also asked Dr. Curigliano and other members of the coordinating steering committee of St. Gallen to focus the questions next time more on that. How do you select the group of patients where you should ask the test? Obviously, because these tests cost money, and we cannot ask them in all patients, and also because if we do, they are not cost effective. And if they are used in selected cases, they are very much cost effective, and they help reducing the cost of treating early breast cancer. So moving to the next question, and as if you attended St. Gallen, you know that I got a little, again, very upset with these answers, because I really don't think that this is the important question to ask. Is a little bit as if 20 years ago we would ask, do you want to use letrozole, anastrozole, or exemestane? So we are going back to discussing small differences when the issue is when to use and what to do with the results. But let's go and go through the results of the voting of the panel. So we have a luminal cancer, ER positive, HER2 negative, node negative disease. When do you think these multi-gene signatures can provide you information on prognosis for the first 5 years? And this information would then have an impact on your decision to omit chemotherapy. and 5 tests were asked, and the question is positive. Let's say that all of them are considered to be valuable in terms of giving you prognostic information about the first 5 years, and also information that can help you omit chemotherapy. Then when we move to node positive disease, the same type of question and the same type of tests, then you see that the decision or the voting of the panel is quite different. And obviously, and everyone knows that you may consider me biased because I was one of the PIs of the MINDACT study, but for the sake of me, I cannot understand how you vote only 43% for the MammaPrint test when you have a randomized prospective trial that has included 1 to 3 positive disease. We are not talking here, and just a clarification, of more than 4 positive nodes, because obviously, and we have answered that question before, that is a clear indication for chemotherapy. So we are talking here of 1 to 3 positive nodes where you would still consider omitting chemotherapy. And as you can see here, the voting is very different according to the test, and people seem to feel more comfortable with Oncotype and PAM50, although the only published randomized prospective trial uses MammaPrint. What about beyond 5 years? So can this multi-gene signature help us to decide who needs to continue endocrine therapy beyond 5 years? So can they provide prognostic information beyond 5 years? And here we have not a consensus, so you have 50 versus 46. My personal opinion is that some of these tests, particularly the second generation of tests, do provide some information on the years 5 to 10 and can be helpful. For example, EndoPredict and Prosigna can provide us some very important and helpful information to take the decision on what to do in the second group of 5 years. So moving on to endocrine therapy, starting with premenopausal patients and asking the questions, when do we need to add ovarian suppression? So the question here was asked for each of these features by itself. So meaning independent of everything else, does this feature by itself argue for the inclusion or for the use of ovarian suppression? And you can see that the 3 questions that were asked: age below 35 years old, premenopausal estrogen levels after adjuvant chemotherapy, and involvement of 4 or more nodes, all considered to be features that would argue on itself. So regarding the use of aromatase inhibitor in combination with ovarian suppression for premenopausal patients, this was the question that was voted. Should some patients receive this combination? But I honestly think that we should have asked a different question and try to dissect which of these patients should be. So when should we consider this clearly more toxic combination? So treating a premenopausal woman with ovarian suppression and an AI is very toxic and very bad for the quality of life. So next time we will need to dissect what type of patients do we consider for this combination, while obviously we are waiting for overall survival results from the soft and text trials. Moving to the postmenopausal patients, one important question is, do we consider tamoxifen appropriate, tamoxifen alone appropriate for some patients? And clearly all of us do consider. And then when asked what parameters do we consider for including an AI at some point, doesn't matter if upfront or in sequence, for the treatment of postmenopausal patients. Do we consider it in all patients? And here you can see that there is no consensus, so the panel is divided. What about for node positive? Most of us would consider grade 3 or high Ki67 also, and HER2 positivity also 60% of the panel members would choose to include an AI at some point. Now, if we use an AI, should we start it up front? In any patient, so in some patients, obviously yes, but most of us would agree that it's basically for higher risk patients. And many people seem to be very strongly supportive of one retrospective analysis of the Big 198 study that seemed to show that lobular cancers do better with letrozole. I would be careful on having such a strong recommendation with just one retrospective analysis of a trial. And we need also to understand why, biologically speaking, this could be true, and we need to confirm it in other studies. So now for the indication of adjuvant and extended adjuvant endocrine therapy. So let's assume that there is a reasonable tolerance to endocrine therapy for the first 5 years, that you have a postmenopausal patient who has been treated with a switch from TAM to AI and has a moderate and high risk of recurrence. So when asked what to do, most panel members would extend the therapy because, as you can see, 83% said that they would not choose no further endocrine therapy. So the majority of them would choose something to continue. That could be to continue AI until a total of 5 years of an AI, and this was the preferred choice for most people, but also continue with further 5 years of TAM or further 5 years of an aromatase inhibitor. When we move for the same type of patient but has received an AI for the first 5 years, then the majority feels that the duration of the AI would depend on tolerance and risk, but would agree to continue to further 3 to 5 years of an AI, while most will not feel comfortable, and I have no reason, I cannot explain to you why. I don't understand this answer, but most people will not feel comfortable to have 3 to 5 years of tamoxifen. I think in all of these, we have to understand the importance of tolerance and compliance. And it's more important that the patient is capable of performing the extended adjuvant therapy if she has sufficient risk than to dwell on how many years of tamoxifen or how many years of an AI should she do. So basically, the one that she tolerates the best is probably the most appropriate one, but this is obviously my personal opinion. Now, for the premenopausal group of patients and those who remain premenopausal after 5 years, do we consider to extend tamoxifen? And most people believe that only when there is a high-risk situation at diagnosis. So again, to remind you that you can send in any comments or questions to Dr. Curigliano. And now for the last part regarding adjuvant chemotherapy. So the first question was, what do we consider on what is important for us to assess prognosis and also the benefit of chemotherapy for node-negative disease? And all of us believe that both immunohistochemistry features but also multi-gene predictor can provide helpful information. Now we would then ask a series of questions or factors. When we use immunohistochemistry, which of the following can be relative indications for chemotherapy? So relative indication mean that it's not always that you need to use chemotherapy, but it will make you think about using chemotherapy. And these are grade 3 tumors, so that is clearly. And then I may have taken bad notes, and we will see when the manuscript is published, but I don't think we have voted on the 4 or more positive notes, because probably this will be a 100% everyone would prescribe chemotherapy. For any positive note, I was also very surprised with this voting, especially because Aaron Goldrich for many, many years have reminded everyone that node positivity by itself, it is not an indication for chemotherapy, not 1, 2, 3 positive nodes. But so it is a bit strange that this voting of any positive node, almost 70% would recommend chemotherapy. Then Ki67 high, also majority would prescribe chemotherapy. Some division on age alone, and again, it has to do with what we discussed previously. We should not overtreat young women just based on age. That is true for radiation and also even more true for chemotherapy. Extensive lymphovascular invasion and low hormone receptor staining, obviously, this would leave no doubt. Now, what type of chemotherapy? So let's start with lumino B-like tumors. And the question is, if chemotherapy is decided, should it include anthracyclines and taxanes? Divided panel, so 52% yes, 40% no. Probably here is where we have more doubts on what is the best chemotherapy to prescribe. My personal opinion, I always give anthracycline followed by taxanes to these patients. And then the question was, should we use 6 cycles of the same therapy, for example, 6 cycles of EC or AC, and I assume also 6 cycles of TC, and the answer is no. Probably a sequential regimen of anthracycline and taxane is the best choice. So moving to triple negative tumors, should the chemotherapy include anthracyclines and taxanes? For stage 1, the panel is divided, as you can see, with a little bit more voting for the yes. For stage 2 and 3, a clear majority saying that yes. What about the inclusion of platinum? And I remind you that we are talking about adjuvant. And do we need to include platinum for all triple negative? Clearly no. What about triple negative with a known BRCA mutation? And here we have a divided panel. And I remind you that we have no data to tell if we should use a platinum in the adjuvant setting. Now, can we avoid chemotherapy in a T1a, PN0 stage? And most of us would agree that yes, even being a triple negative, we may consider in some situations not providing any therapy. And should those dens be preferred? Also a voting hard for me to understand, because all trials and all available trials have shown a benefit of those dens for highly proliferative tumors. So for HER2 positive, and starting with the node positive disease, should chemotherapy be given to all patients with node positive disease that require anti-HER2 therapy? And the answer is yes. And should it include anthracyclines? Majority of the panel also considered yes. And the same also should include taxanes. So again, a sequence of anthracyclines and taxanes is the most appropriate choice for the majority of the panel. So when we were asked about node negative disease, and starting with the question of anti-HER2 therapy, do you prescribe anti-HER2 therapy for any T1 tumor? And for T1A, most of the panel would not prescribe anti-HER2 therapy, while for T1B and C, the answer was yes. Regarding this combination of paclitaxel and trastuzumab, and I remind you that this is a non-randomized, single-arm, phase 2 trial that has given a lot of weight recently, but we need to look carefully that it's a not randomized phase 2 trial. But it seems that most people of the panel are comfortable with this regimen up until 2 centimeters, but not above 2 centimeters. And for the combination of docetaxel, cyclophosphamide, and trastuzumab, is it a reasonable option? And I suppose for some patients, and the answer was yes. Now, what about the use of pertuzumab? So in terms of adjuvant treatment, we can only recommend at this time 1 year of trastuzumab alone. And even for those who receive trastuzumab, pertuzumab in the neoadjuvant setting, we will have the results of affinity at ASCO, and we'll be able to maybe revote this question about the use of dual blockade in the adjuvant setting. And regarding the use of biosimilars, 54% of panel members are comfortable with the current evidence, but there is a huge percentage of abstain, probably because not everyone is totally aware of all the current evidence. These next 2 slides I will go very quickly, but the main message is to tell you that clearly there is a push for the use of neoadjuvant systemic therapy in the neoadjuvant set. So for the neoadjuvant setting in HER2 positive and triple negative tumors. So in particular for stage 2 and 3, we should prefer neoadjuvant approach when there is a HER2 positive or a triple negative cancer. And then in the neoadjuvant setting, most panel members would prefer to go with a dual blockade, although still 35% will consider taxane trastuzumab an adequate choice. And the triple negative, as I said, the same, prefer neoadjuvant approach. What about the use of platinum or alkylating agent? Everyone thinks that we should use. I would have liked to vote separately, one or the other, but we voted together. And most people also believe that a sequence of anthracycline and taxane is probably the best option. A few would also consider to use nab-paclitaxel. So the post-neoadjuvant therapy, which is something that we are more and more confronting, so let's say that there is a residual disease more than 1 centimeter, or there are positive lymph nodes after anthracycline and taxane and alkylator based therapy for triple negative. Would we be comfortable not prescribing any more chemotherapy? And 31% would still not prescribe any more chemotherapy, while 49% believe that the results of the CREATE-X study are sufficient to prescribe capecitabine. So I would say that it depends also on other characteristics, but we can certainly try to dissect that more. And lastly, the use of bisphosphonates in the adjuvant setting with the aim of improving disease-free survival. So can we do that in postmenopausal patients? Definitely yes. In premenopausal patients that are not having ovarian suppression, definitely no. And where there are more difficulties in replying or less consensus is for premenopausal patients that are receiving ovarian suppression with tamoxifen or an AI. And when asked if we can do it with denosumab, for the moment, the panel is very much divided to provide a clear recommendation if you can do that using denosumab. And I think I will stop here so that we have some time for discussions and give the word to Dr. Curigliano.
Okay, thank you very much, Fatima. You did an excellent job, I believe, with many criticism. And we have a lot of questions, so be prepared to answer the questions. So first one is a set of questions on the Ki67 role in deciding the adjuvant treatment. So the question is how to define a high Ki67, how to define a low, and finally, can you tell us something about reproducibility of Ki67 in different labs?
Okay, so my take on Ki67 is that it got a bad reputation from the start and is fighting very hard to get away from that bad reputation. But people should also remember that we also have false results in ER and PR, and particularly in PR. there are some difficulties in all immunohistochemistry. So first of all, you have to trust your pathology, and your pathologist must be experienced in assessing all these markers. And also it is recommended that your pathology must assess what is the average percentage of positivity in that specific lab. And that will help a lot for you to define your cutoff of high and low. There are, however, some cutoffs that we all agree on. And let's say that if it's below 10% or below 15%, I think everyone agrees it's low. And then above anything that 35, 40%, also everyone agrees that it's high. It's that intermediate gray area where it's hard to decide. But honestly, even if I would work with the best pathologist, I would not decide only based on Ki-67 in that gray area. So I would need grade, I would need the age, the size of the tumor, the level of positivity of ER and PR. So there are many other things that you take into consideration. And obviously that can be the situation if you can afford, where a multi-gene testing would be quite good.
Okay, very good. Another question is related to the role of progestinic receptor. So do you still believe that a low PGR should be a prognostic factor in order to decide to give or not a chemotherapy outside the gene testing?
Well, again, PR is also a difficult marker with immunohistochemistry. I think that it probably has even more problems than Ki-67, although we don't treat him so badly, let's say. But so I would not use it alone to take that decision. But again, if you have low PR and intermediate Ki-67, now you have already two factors that make you wonder what are you going to do. So not alone, but it adds some help.
Now we have several questions on endocrine therapy in premenopausal women. So the first set of questions is related to the patients that should receive 10 years of tamoxifen. So if you have to select these patients, which are the criteria to propose 10 years of tamoxifen?
So I think we need to be honest with each other, and the trials we have with extended adjuvant therapy do not help us to dissect who needs it, because the results are everyone needs it. So how do we dissect if the trials have not done so? So I think the only thing we can do is look at the risk. And if it's really low risk, I would not extend beyond 10 years. If it is high risk, I would do so. If it is intermediate, I sometimes do something that clearly it's not evidence-based, but I discuss with the patient up until when she's willing to take, between 5 and 10 years, 7, 8, because you also need to make sure that she is willing to continue to take the tamoxifen, but we have no data to help us there.
And the next question is related to ovarian function suppression plus AI. So the question is, who are the patients who should receive this combination?
Yeah, and as I said in the presentation, I think next time we need maybe to have a few questions on trying to dissect who are the patients who need this combination. My personal experience, I think yours too, and many people, is that this combination is difficult to tolerate. Although some patients seem to be okay with it, but for the majority of patients, it's a hard combination. So I would say very high risk patients. So what do I mean by that? Very high tumor burden, either 4 or more positive nodes or very large tumors who may not have responded well to neoadjuvant treatment, and you still have a lot of residual tumor. So those kind of situations. But for example, if you ask me, oh, only because there is high Ki-67 or only because there is grade 3, I feel very uncomfortable with that.
And another question is related to the menopausal status. In the real life, how do you define a patient's premenopausal or postmenopausal? We received a lot of questions on this.
So I guess the premenopausal is easy, right? So how do you define postmenopausal? That is more complicated. So I think the most important message that we should pass on is please do not use an aromatase inhibitor alone if you are not 100% sure that it's postmenopausal, because that is the most common mistake I see and the most dangerous one, because sometimes you have a lady above 45, so between 45 and 50, which is the most difficult situation. She becomes amenorrheic after chemotherapy, and you dose the estrogen levels and they are low, okay? But if you give an aromatase inhibitor in that situation alone, and you dose the levels again, in many, many cases, they rise up. And so if you want to give an AI in that situation, you must follow very closely, and that means every 6 weeks, the levels of estrogen to see if you're not stimulating the ovaries back into function. And I guess that's the main issue that we have here, because the definitions are there. You need to wait 2 years, they need to be amenorrheic for 2 years, but I would be very careful with giving AIs with 45 to 50 without checking estrogen levels.
And so speaking about estrogen receptor levels, so which is the minimum cutoff to prescribe an endocrine therapy? Starting from the consideration that only ER positive should receive endocrine therapy, because someone asked also if ER negative and PGR positive should receive. So which is the cutoff for ER positive?
So I agree with you. ER negative, PR positive, we must triple check, because in principle it should not exist. And we do have some data from the Oxford overview saying that in that category of patients, it seems there is a little benefit of endocrine therapy, but I feel very uncomfortable to prescribe endocrine therapy there. And for ER, I would say clearly above 10%.
Perfect.
Below 10%, it's complicated.
Now we move to HER2 positive population. And the first question is, why neoadjuvant chemotherapy plus trastuzumab or trastuzumab and pertuzumab to patients with HER2 positive? And if you confirm that all the patients should receive, would you define a specific stage for neoadjuvant chemotherapy and targeted therapy in this setting?
Okay, so as I said in my presentation, I think this was let's say a progress, an improvement from the last St. Gallen, and clearly our recommendation is use the neoadjuvant setting as much as possible when you are sure that you should give chemotherapy. And I know that we only discussed that mostly for HER2 positive and triple negative, but I would add, and this is what I do in my clinical practice, also for the luminal B tumors where you are sure you're going to give chemotherapy. Because if you already know that you are going to give, it is better to give it neoadjuvantly, see the response to therapy, see the pathological complete response, how it is, or if it doesn't occur. And that will give you prognostic information and will also help you later on. So, and if you are going to do it, if you don't need any more information, for example, sometimes we are in doubt and we need a clear axillary evaluation. Okay, then we can go for adjuvant setting. So for me, it's quite clear. Unless for small tumors, I always go for neoadjuvant setting.
Perfect. Now, two specific questions on de-escalation. The first question is, did I get right? No trastuzumab and chemotherapy for PT1A, PN0, HER2 positive tumors?
Well, you got right the percentage of voting. It doesn't mean that we all agree on that. And I think that, so let's take one at a time. So PT1A, N0 tumors, and T-HER2 therapy or not. And the fact is that we have almost no data to answer those questions. We have from 5 millimeters on. Okay, we have some data, not a lot of data, but some data. But below 5 millimeters, we have actually no data to say that we need to prescribe anti-HER2. So that's why you saw this percentage of voting. And what about chemotherapy in those patients? My take on that is that I need the ER status, okay? So if it's ER positive, HER2 positive, PT1A, you can give endocrine therapy and no chemotherapy is necessary. If it is ER negative, HER2 positive, that I would say that it's more complicated. But as you can see also in the voting of PT1A and 0 triple negative, a lot of people feel comfortable not prescribing chemotherapy. So it's the same situation. And I guess there I would take into account the age of the patient, not because I think young women should be overtreated, but because they have more time to have a relapse. And eventually also comorbidities, and if you feel that, you know, and also obviously something we have not discussed, but the preference of the patient is very much important here when we don't have strong level of evidence.
Thank you. It's correct, because the St. Gallen is for area where we don't have evidence, and so we take in consideration the expert opinion. And finally, the last question is related to the bone health statement. So what do you think, your personal opinion on the statement to support bisphosphonate for postmenopausal women ER positive?
So the way we are doing it in our clinical practice is that we are not using it for premenopausal patients with or without ovarian suppression. I don't think we have enough data, not even from the Oxford overview would looked into the meta-analysis of all available data. For postmenopausal, I think we have quite interesting hints that may provide you some help. And I would say that there are two situations here. If you are going to use an aromatase inhibitor, you might as well think that the bisphosphonates will have two benefits. I mean, they will have the benefit of bone health and the potential benefit of disease-free survival. So particularly if there is a high risk, I would consider administering the adjuvant bisphosphonates.
And what do you think about supplementation of vitamin D and calcium in patients receiving aromatase inhibitors?
Well, I think it is something that you should not forget. We usually, I mean, we are worried with so many other things that we sometimes forget the bone health, and it's important to try to avoid osteoporosis. And I didn't go through my last slide that look into the recommendations for lifestyle modifications, but as you remember, Giuseppe, Pamela Goodwin explained that it is good to have a healthy lifestyle, but if you are doing certain things just to reduce the risk of recurrence, we actually don't have a lot of strong evidence. But regarding levels of vitamin D and physical exercise, I would say that these are the two where the results seem to go in the same direction and where they may be good to do both normal levels of vitamin D and some level of exercise.
Thank you very much indeed for the excellent discussion, and I would like to thank all the audience for the many questions, and of course to Professor Cardoso for the excellent highlights on the St. Gallen 2017. Thank you very much. Bye-bye.
Bye.